very much the organizers for this opportunity, and we're talking about TheraSpheres, a little overview on what TheraSpheres is. Some of the slides I think Dr. Ashraf has already covered, so I'm going to be a little quick on those. As Dr. Ashraf said clearly that this is liver cancer and it's a difficult treatment. We have very few effective treatment options actually available, and these are because the liver functions are bad by the time the patient arrives to you. We see that the patient is sick. Once we try to treat them, there's a risk of decompensation. We also know that chemotherapy and low dose of radiation has poor response, but we've also learned and we've understood that high dose of radiation is responsive. However, if we look at some of the options in terms of resection or transplantation, only about 5 or 10% of the patients have these options. Rest fall into palliative treatments, and these palliative treatments are radiofrequency ablation, chemoembolization, which has been going on since years and years, and now we have transarterial chemoembolization, Y90. What is TheraSpheres? It's a powerful, well-tolerated yttrium-90 glass microsphere therapy for transarterial radioembolization, very effective for primary and secondary liver cancer. With this is more like a selective internal therapy, and a very high localized dose of radiation can be delivered to the tumor. These are often 20 to 30 microns in size. They are like glass microspheres. If you see here, they are like 1/3 the size of human hair, and yttrium-90 is actually embedded inside the glass matrix of these solid spheres. So once it's injected through the bloodstream, they travel and get lodged in the capillary of the tumor, and there's no leaching because everything is inside the glass matrix. This is how it is once you inject these microspheres. If you see here, these black tiny microspheres lodged in the capillary of the tumors, they stay there and give a very high localized dose of radiation. The concept of this whole treatment is based on the hypervascularity. More vascular the tumors are, the better the tumor absorbs these microspheres, and better radiation dose is delivered to the tumor. Let's look at some of the benefits of TheraSpheres. It's a low toxicity, well tolerated outpatient procedure. As we said, since Dr. Ashraf mentioned that the number of particles in TheraSpheres are low, so the post-embolization syndromes are very less, and when you really compare this with transarterial chemoembolization, this is the quality of life is quite well maintained. We have promising survival data. It can be used as a bridge to transplant, as a new adjunctive to surgery. As I said, we can use this for primary and secondary liver cancer, and in fact this is the only modality as far as now which is approved for portal vein thrombus. So you can use this with in hepatocellular carcinoma with or without portal vein thrombus. The most important part of this is it's very easy to use. It takes about 5 minutes for infusion, and then post TheraSpheres patients are eligible for further options. As we do not embolize or totally occlude the vessel, you can still go ahead and treat the patients with TACE or any other form of treatment because the vascularity is quite maintained. Talking about the vascularity, if we inject these microspheres in the right lobe where there is no tumor, you see a uniform distribution of microspheres going into the right lobe, versus if you have a hypervascular tumor and you infuse from the same position, you see that almost all microspheres now, like 95% of them are now in the tumor and very less to the normal parenchyma of the liver. So this is a very safe, selective internal therapy, and does not really affect the normal parenchyma if safely administered and through a correct way. This is an external beam radiation where you have the radiation going from outside to inside, versus TheraSpheres or radioembolization. When you talk about the radiation is from inside to outside, so very less damage to the normal current canal. As compared, Dr. Ashraf mentioned there are two types of microspheres, resin and glass, and I won't go much into details, but as he correctly said, that the specific activity is much higher for TheraSpheres, and thereby resulting in very less number of microspheres for TheraSpheres. When you compare this with chemoembolization, and the concept of chemoembolization, as we know all, is you totally occlude this and you get an ischemic effect. With radioembolization, you do not alter the vascularity, especially with TheraSpheres, and there's still blood flow, and this is where we all understand that if the blood flow is not compromised, the oxygenation really helps in long-term radiation effect in terms of response and tumor shrinkage. When we look at TACE versus radioembolization, TheraSpheres, if you see here, in almost all instances, TheraSpheres can be used, but however, TACE still cannot be used in certain criterias, in certain indications. So thereby, radioembolization really seems to be far more superior when you compare this with TACE, and I'll talk about this a little later in some of the later studies. Again, tumor vascularity, this is like a pre-treatment angiogram. If you say the vessels, if you look here, and this is 45 days post, if you see here, it's almost total necrosis, but the vessels are still patent. You see no changes in the vessel. So it does not really alter the vasculature of the tumor. This definitely comes with some form of common adverse events, and the major fatigue is what we've really observed in radioembolization, and mild abdominal pain, which can be very well organized if you start the patients with a proton or some steroids. What is the whole treatment approach, patient selection? Let's look at this. This is a team effort for centers who are looking at starting. This is a team effort with interventional radiologist. You have nuclear medicine team coming together, and then you have these whole people supporting and sending patients to either the interventional radiologist or the nuclear medicine. Depending on which country you are, various countries have different license issues. As Dr. Ashraf said, this is an initial workout of the patient. The patient comes, you have to evaluate whether the patient is suitable for TheraSpheres or not. You do a lung shunt, inject few millicuries of technetium. This is where you see there is some amount of lung uptake. You obtain a tumor volume. We need a liver perfused mass. We have a formula which we put all the calculations inside. The dose is calculated. We manufacture 6 dose vial, 20, 15, 10, 7, 5 and 3 based on what the patient needs, depending on what the vascularity is, depending on the liver function, the lung shunt. You decide on which dose is best suited. You order the dose comes to you, and in fact the whole formula we have put it in a software. So as soon as you put the findings in the software, the lung shunt and the volume, the software actually tells you which dose you have to order and which day you can actually infuse it to give that kind of activity. This is how the administration kit looks like. We changed this 2 years ago. This is a brand new kit. Very, very simple. It takes about 5 to 10 minutes to assemble this whole kit. And this is how it looks. Once you infuse this, it takes again about 5 minutes to infuse the whole dose. It takes about 40 to 60 cc to administer this. Once you've done the infusion, the whole setup can be taken aside and then can be just checked for any form of contamination. This is the regular routine nuclear medicine and RSO activity which is done all over. The patient is then, dose exposure is taken from the patient. There is some series of calculations which will actually tell you that what amount of dose was actually delivered to the patient, what percentage of dose actually was delivered to the patient. Of course, radiation handling can be a challenge, but however, this can be overcome once you basically follow a set safety profile. One good thing with TheraSpheres is that the TheraSpheres dose vial is actually a ready-to-use dose vial and does not need any site calibration. So you just open the vial and you put in the kit and you infuse. Let's look at some of the clinical outcomes. This is a study done some time back. And all these studies, if you look at, shows very significant response in terms of survival and in terms of also the tumor responses. This slide you've already seen, so I'll skip this one. Large hepatoma. You see here 30 days, no significant. There is some necrosis, but not significant reduction in tumor size. But as you go 15 months, you see significant reduction in tumor size. The message here maybe is that at this point, when you look for response and you see that there is no change in the tumor size, there could be an option to look at other liver functions to see if the AFP probably has gone down, and look at some form of response. And once you look at that form of response, there's always a good chance that you can wait and you will see the tumor response in due course of time. Again, large hepatomas. I'm going to skip this slide. This is a dome lesion, and if you see here, there's a ring enhancement which looks like a viable disease. But on explant, it's actually total necrosis, and which may have felt like a viable disease is a ring enhancement, is a fibrous capsule. So imaging is always a limiting factor. However, we definitely work through with various ways. Again, a dome lesion, and if you see here, 61-year-old patient, elevated bilirubin. So in this case, a segmentectomy was opted for, and a high dose was given. However, they made sure that everything was going in the tumor, and this is the response, total necrosis. This is from mesothelial, dramatic response, near response. Portal vein thrombus, if you see, we definitely come across many patients where we have hepatomas with portal vein involvement, and this is a massive PVT, vein PVT, and if you see here, near complete resolution of PVT in 1 year's time. Again, hepatoma and invasion PVT, and if you see here, 26 months, near complete response and AFP dropping down. Both lesions, if you see here, again, classic example, this is one of those classic examples, and you see in an elderly patient and dramatic response, and then TACE was actually followed after TheraSphere. So this also gives an indication that many a times you don't really have to look at radioembolization only, but it's sometimes more like a combination therapy. This is a study which was done some time back, again on 150 patients, and they looked at T3 size tumors. These tumors were just outside Milan criteria, and the intent was, can you bring down from T3 to T2, or as a downstage to resection or downstage to RFA. And if you look at the results here, 56%, 19 patients out of the 34 patients are now T2. 11 patients out of the 34 downstage target lesion less than 3 centimeters. And one patient at the time when this was published went to press, went for liver transplantation. So overall, the intent was 66%. Again, if you see here, this is complete explant, complete necrosis, fibrous capsule, and some radiation necrosis to the healthy tissue. And a high dose, 326 gray, was actually delivered to this patient. So you can actually reach very high doses with this, with a median survival of 800 days, 1 year, 2 years, and 3 years in 84%, 54%, and 27%. Conclusion for this particular therapy was TheraSphere offers a low toxicity option for downsstaging, surgical resection, RFA, or as a bridge to transplant. Post-embolization syndromes as compared to traditional embolization procedures were far less. This is a recent study done comparing chemoembolization versus radioembolization. Dr. Ashraf did talk about this, and let's take a little bit on more details on this. This is on 43 patients. If you look at both segments, they were T3 outside Milan criteria. And if you look here, and in the grade 3 and 4 bilirubin toxicity, TACE is 26% versus only 7% with TheraSpheres. And even in the tumor downstage size, you can see some difference. Most importantly, T3 to T2 downstaging nearly doubled. So you can achieve double downstage when you look at TheraSpheres. Event-free survival 7.5 months versus and 17.7 months. Another study, chemoembolization versus radioembolization, TheraSpheres, and this is majorly on the toxicities. Again, in a large group of patients, 122 and 123, and I'll quickly go through this. The mean treatment which was required here was 2 versus only 1 with radioembolization, and hospital stay is 3.4 days with 0 days with TheraSpheres and the various drugs. And if you look here, the time to response is much faster than when you compare with TACE. When you look at the overall toxicities, time to progression is 8.4 months and 13.3 months with TheraSpheres, and overall survival is almost 3 months more. So if you have to look at overall survival, we probably have to look at more number of patients, and 122 would be far less. This is a study on 291 patients. I won't spend much time, but quickly, if you look at the child's A patients in the in T3 large tumors, you have about 35.7 months survival. When you look at child's B patients in the same group T3, you have 38.3 months survival. And the same study was again replicated by the Germans, by the Essen group, and near similar response with this also. Let's look at liver metastases, last few slides. This is on 137 patients, colon, breast, neuroendocrine, cholangiocarcinoma. And if you see here, according to WHO, 42% response, but radiologic response is almost 90%. That means these tumors did show some response, but however, they didn't meet the WHO criteria. Overall, median survival was 300 days. In colorectal mets, it was 457, and neuroendocrine is almost 800 days survival. Conclusion, radioembolization is a treatment option in patients with chemorefractive liver metastases. Treatment able to halt or reverse progression in almost 87% of the patients, and promising survival benefits. This is again a study on 72 patients and almost similar results. And if you see here, median time for hepatic progression is 15.4 months. So conclusion overall on liver metastasis, Y90 seems to be a better option for patients with preserved liver functions. Y90 does not impair the ability to receive subsequent active chemotherapy. Mostly this is used in first line, where the first line and second line of chemotherapy may not be responding. It's a good time to look at using the Y90, and then followed by another few more cycles of chemoembolization. So we are working on a lot of aspects. At our end, we're working on dosimetry. We are working on, this is a flow dynamic therapy. We all understand there's a lot to be done in this. It's minimally embolic. We are actually getting into some clinical studies. We've also announced some, but I will not go right now into this. These are some of the centers which we are using TheraSpheres.